So good morning, everyone. My name is Lisa Dolovich. I'm a professor and dean at the Leslie Dan Faculty of Pharmacy at the University of Toronto. Really pleased to be able to have you all here today. On behalf of the Centre for Practice Excellence at the Leslie Dan Faculty of Pharmacy and the Ontario Pharmacy Evidence Network are open. We are thrilled that we've been able to pull this event together and focus on virtual care. I want to just remind people that we are going to hold the event while people's mics and video are generally off, because we do thankfully and wonderfully have a large number of people joining us today. And so I'll thank you right now to keep your microphones and video off, and I'll talk to you a little bit about how we'll interact with one another really quite shortly. As you all know, virtual care has really taken storm right now in the healthcare system. It's been something that not only pharmacy, but most of the healthcare system has been grappling with and transforming to. Lots of innovation has been happening, and we think that this will be something we hope that stays with us even through and beyond the situation that we have with the COVID-19 pandemic. And so because of all this innovation, we thought we should bring people together and talk about all of the great things that are happening, learn from one another, and as we share ideas, take these back to our own settings and be able to innovate and provide an opportunity for future research ideas, as well as have our students have great educational experiences in environments that are rapidly changing. So, Annalise, I'm just going to have you go through to the next slides if you don't mind. Thanks so much. I'll have you go to the next one. Yeah, that's great. And the next one as well. So, so what we hope we'll do for the day is that we're going to focus first on a plenary presentation. I'm going to introduce our plenary speaker in a moment. And then when he is finished with his remarks, we'll have the opportunity to have question and answer session with him. So if people have questions or comments, please feel free to put them in the chat window. We'll be moderating and monitoring the chat window through the presentation and afterwards, so that people can have their voices heard that way, where we'll read out questions and comments, and the presenter, including Onil and the next presenters of the day, can answer them. Once our plenary is finished, thanks Annalise for moving to the next slide, we will have 3 presentations. Sorry, I think our slides and our audio is not always working probably in concert, but we'll have a session. We'll have 3 invited oral presentations, and again, thanks to those of you who submitted abstracts. We had a huge number of people submit abstracts. We have 3 presentations in our first session, and we'll have each of the presenters present. There'll be time for 1 or 2 questions after each presenter if they haven't used up their time during that presentation, and then we'll have a bit of time at the end of each session for a Q&A, and then we'll have a break, and then we'll move to our second session, which is another 3 oral presentations, where we'll have a few questions after each session, and then time at the end for a larger group discussion. And then of course we'll close out the morning. So I'll hope that people have understood now how we're going to move through the day, and I now get the great pleasure of introducing Onil Bhattacharyya, who is our plenary speaker for the day. He's going to be talking about virtual primary care and how we're navigating the swift shift and establishing a new normal. Onil is the Frigyung Blau Chair in Family Medicine Research at Women's College Hospital. He practices family medicine and is an associate professor in the Department of Family and Community Medicine and the Institute of Health Policy Management and Evaluation at the University of Toronto. He's also the national co-chair of the Primary and Integrated Healthcare Innovation Network, funded by CIHR. He's really a true leader in primary care research and contribution to policy development in terms of transformation of our healthcare system, with a focus on health services and primary healthcare. So I'm really thrilled that Onil can join us today to talk about all that is happening from his perspective in primary care, and how that can help us be informed in pharmacy in terms of pharmacy practice, but how pharmacy fits into the bigger picture in terms of the healthcare system. And I know there's a lot we can learn from having that broader and wider perspective. So Onil, I will turn it over to you and look forward to your remarks.
Okay, thank you very much. I'm just trying to figure out how to share my screen. Share. So how do I? Good morning, everyone. Just give me 2 seconds to sort out the screen share. Annalise, can you see my screen?
Yeah, that looks great.
We can, thanks.
Perfect. Oh, great. All right, well, thank you so much for the opportunity to speak, Lisa. I'm really happy to chat about the experience of virtual primary care in this, the new world that we now live in. As someone who's been studying this stuff for several years and really trying to push people to adopt it, it's very gratifying that people went from saying, oh, it might be nice to do this one day to how do I do this now? And so I want to talk a little bit about the shift that we've seen in the COVID era. I want to talk a little bit, I'll start with the value proposition of virtual primary care in the pre-COVID era. Really the goal was to just have appropriate care. And it wasn't really about reducing infectious disease transmission. Then I'll talk about what happened during COVID and then end on sort of what's the future state, what is the future of virtual primary care and how does it fit into our sort of broader agenda. I'm going to keep the focus probably mostly on Ontario, where a lot of my work is funded by the Ontario Telemedicine Network, as well as the Center for Digital Health Evaluation based at the Ministry of Health's Digital Health Division. And so that sort of shapes my perspective. So when we think about primary care, the idea of virtual really brought the idea of a GP at hand and primary care at your fingertips. Now, until recently, this was not really the case. When you looked at, this is a survey conducted by the Commonwealth Fund based out of the United States. They looked at 11 different countries and asked patients whether the practice offered the option to communicate via email or secure websites. And so at that time, Canada was definitely not a leader in this area. 22% of people said yes, as compared to 90% in Sweden, 80% in Switzerland, et cetera. So we were not leaders in virtual care coming into, prior to COVID. One of the pilots that was done that started in 2018 and ran into 2019 was funded by the Ontario Telemedicine Network, and they're really trying to promote uptake. So what they did, they recruited family physicians from 5 different LHINs, or local health integration networks, to approach their own patients and recruit them. And they gave access to a free platform as well as billing codes for both video and asynchronous text. And patients could choose any modality, so asynchronous messaging, audio, or video, and the physicians had 24 hours, or sorry, up to 2 business days to respond. And so this was sort of marketed to a large number of physicians to recruit their own patients. And so this is in distinction with a kind of Maple or virtual walk-in model. I think at this point, the ministry was very keen to improve access for primary care, to their own doctors. And so over the 18 months of the pilot, 194 primary care providers gave at least one or had at least one visit. Over 14,000 patients registered, and there were over 14,000 visits. So I'll talk through briefly the findings of this to show the value of that they found. So from patient experience perspective, this one's pretty obvious, but the numbers are still striking. 98% felt that the visit was the same or better than in-person care for the issue that they brought up, right? Doesn't mean for every single problem, but for the problems that they selected, this was the same or better. 99.9% said that they would use the virtual visit again, and 91% said that make accessing care more convenient. One of the interesting things in the pilot was that you had 2 business days to respond. So we thought people would be very keen on rapid feedback and timeliness, but actually convenience mattered more to them. The fact that it didn't have to drive anywhere, didn't have to wait in an office, didn't have to take time off work, these were seen as immensely valuable. And overall, you can see that it saved patients time and money. 75% said it saved them money compared to in-person visits, and 93% felt that it saved time. So these things were more valuable to patients than timeliness for the patient, for the issues that they brought up. All right, so what modalities were used and how were they used? So over 195 days, this is the number of visits people had, and you can see 56% of people had no visits. And so overall 79% had one or fewer visits during the project. Only 2%, if you can see that little green slice, had more than 7 visits. And we don't know exactly what was done in each visit, so we can't comment on the appropriateness, but there's a sense that, for certain uses for chronic disease management, even 7+ visits might be appropriate, but the vast majority did not overuse the platform. For the most part, one of the questions the ministry had in this study was, is this a substitute or is this added on? So we found that virtual visits replaced in-person visits. And we asked people, what would you have done if you didn't have this? 67% said they would have booked an in-person visit with their doctor. 15% said they would have gone to a walk-in. And you'll note that only 5% would have done nothing. So it did not appear to add on to existing care. It really appeared to substitute to a more convenient modality. When we look at the types of messages, what you see here is the requested, so there's 2 bars. 77% of what was requested by patients was asynchronous messaging, and 12% audio, only 2% video. The next bar is what was used. And here you can see that even though patients often requested, requested a message or audio or video, often they were, it was shifted to an asynchronous text by the physician. Part of the reason for this is that the pilot didn't include a scheduling platform, and doctors often set this up on their own. And so as a result, asynchronous text is the easiest thing to schedule because you just fit it in wherever, whenever you have time. Now, in terms of the visits, what we found is that 81% of e-visits required no additional follow-up, and there were fewer no issues with patients using the platform inappropriately from the provider perspective. So overall, for the patient perspective, clearly a big win. The provider experience, there were multiple benefits for providers. So they found that it increased the number of patients they could see in a day. They received compensation for work that they previously did by phone or email, because now you're able to bill for text and you can give lab results, follow up on side effects and a range of other messages. It was secure, more secure than email. Many of the doctors were using email and then switched to this platform. And in terms of quality, the things that they highlighted was that it gave them time to think before responding, it reduced wait times, and it gave an opportunity for reminders and to give additional information. So many benefits over face-to-face care from the provider perspective. In terms of workload, this was really the main fear when people came onto this. So there was 35 days before from the registration for the provider to have the first visit. It was less than 1 visit a day on average. 61% of providers closed visits within 2 days. On average, it was about 2.5 messages per visit. And most were able to set boundaries and describe appropriate use. So in the pre-COVID time, this was managed, was not overwhelming. That was really the first step, is giving people a platform. But really, the next step here was really to define communication channels. And so when you think about communication channels, there's 2 parameters that matter. One is time, whether you schedule and how you schedule. And is the interaction going to be live, asynchronous, or undefined? And the second is the medium. Is it text, image, audio, video, notification, or in person? And I think this has led us to think more broadly about how do we manage communication channels in primary care. It's something that people in marketing and retail have been doing for over a decade, but is now, sort of just coming into primary care. So in terms of managing these channels, the first is understanding the fit between the medium and the context. You got to understand the configuration of patient problem and provider to figure out what's the right approach, and then really invest in workflow redesign, training, and analytics. So triage by either a nurse or a chatbot to address suggested modality based on person's need, patients learning to request and use the best modalities, and clinicians learning what works best for them and their practice. In our 18-month pilot, really this workflow redesign was just kind of happening probably halfway through for some practices. So the potential really was not fully realized, and that's something that people are just coming into now. So what about virtual care in response to COVID? Because really now this is when it has exploded. And what we're seeing varies a lot across jurisdictions. You know, one of the most striking examples is in France, where one of their major platforms, so they released billing codes before COVID. So they had billing codes for text and video. They had a major platform called Doctolib that had brand recognition and was readily available. And so that platform, Doctolib, went from having 100,000 visits in 2019 to 2.5 million visits by April of 2020. And that's just, you know, increasing very rapidly. So they were able to shift to, you know, a general platform and quite a bit of video in that time frame. If we contrast with Ontario, what we had was a shift in billing codes that happened shortly after the beginning of the pandemic and the lockdown. And those billing codes included both phone and video and did not include asynchronous text. So the uptake that we've seen, so Canada Health Info estimates that 60% of care is virtual currently, but the vast majority of that is telephone. And that's partly because the video though they are available, people in that rapid shift, particularly in primary care, you know, signing up for these things and going through registration processes and so forth was challenging. One of the things that the ministry did was essentially say, you know, use any platform you can. And in fact, the provincial platform, the Ontario Telemedicine Network, was completely overwhelmed initially, and they couldn't handle the volume. So they were suggesting that people use different platforms at that time. So this, you know, uptake of different communication channels has varied over time. And as you can see, we are kind of mostly on the phone side. In the UK, they've had a similar transition where there is some video, but phone is still the dominant modality. We're currently collecting, so there's a series of surveys going out in primary care this week actually to understand what the real proportions are in Ontario. So I don't have detailed data, but I can show you my own clinic at Women's College Hospital. If you look here, this top one, I'm sorry, is kind of small, but in our family practice, we have in April of 2020, we had 800 in-person visits versus 3,600 virtual visits. So over 80% of our visits are virtual. And again, those are majority telephone with a subset being video. So one of the questions that comes up in COVID is really, you know, for a given interaction, does it need to be in-person or virtual? And so for each patient, you need to think about what is the disease severity, what is the risk of missing a diagnosis, of delaying treatment, and potential harm from, you know, having a virtual visit, and what is the patient's capacity for virtual self-management? Can they manage the technology? Are they proactive? Are they activated, et cetera? And so when disease severity is high and you need more information that you can get over virtually, you're going to have more regular in-person visits. When capacity for virtual self-management is low, you need to think about how do you train that up. And the last parameter, obviously, is like the reason that we are doing so much virtual is we're trying to minimize in-office transmission of infectious diseases, particularly COVID. But the proportion of virtual versus in-person is going to shift as the pandemic shifts, depending on the infection, you know, community transmission rates in the region where you are at the time you're in. So this is a kind of a complicated decision point for providers and a new way of thinking about how we manage communication channels and care delivery. We're working with the Center for Effective Practice on a series of guides. We just did one on diabetes, but we're going to look at a wide range of conditions. And interestingly, at the beginning of the pandemic, you know, we were managing low back pain over the phone, which is, you know, doesn't seem reasonable, and having lots of patients do self-physical exams or partners doing physical exams over video, et cetera. So those are things that in acute care were probably not super safe, but were appropriate given the degree of disease transmission in community. So I'm just going to close talking about what are the next phases. So we're managing the pandemic, the numbers are coming down. We are now thinking about what is the long-term impact of this for our system. And for me, it's really about building a primary and integrated healthcare system. How does digital health and virtual fit into that bigger system? Remember OHTs? So Ontario Health Teams are really, I think, once the ministry has gotten through this pandemic response, is going to go back to thinking about integrated teams at a regional level and how they work. And so this is where digital health can really deliver. And really it's about, for me, from a primary care perspective, is rethinking what is the behavior of primary care? Are we to continue behaving like a bunch of independent shopkeepers running a small business? Or do we behave like the entry point to an integrated system that provides seamless care that is oriented around a patient? If we move into the latter model, then we need to think about what are the building blocks of modern primary care. Virtual visits are one of those core, and we just talked about those. The pieces of virtual visits that are not so well developed currently are triage mechanisms that allow you to figure out, is this a clerical issue? Is it a clinical issue? Can we provide self-care advice? Or does it need to go to a doctor, nurse, or other provider, pharmacist, et cetera? How do we build education into those visits and make it easy to transmit information? And how do we manage every available channel in the best possible way? So still lots of work to be done, but the uptake here has been encouraging. The next step is care coordination platforms. If we're going to operate like an integrated health system, then we need to figure out how to work across every level of care. And so here what we need are shared care plans that are updated and adapted by any provider, and negotiated conversations where input from primary care, from specialists, from pharmacists, from every different group allow us to agree on what is a plan at a point in time, delegate tasks to different members of a team, which may be based in different institutions, and then update that plan over time. There you see a little bit of this in cancer, but in routine primary care, this is not the norm. The platforms are out there. There's one called Atonix, which we've trialed in one with rural elderly and frail elderly in a rural area, but uptake has been very minimal. So there's still lots of work to be done on that, but that's another key building block. And the last one is remote monitoring. And this is an area that's gotten a shot in the arm because of COVID. In our clinic, we set up a COVID at home model where we monitor people who are COVID positive at home and using video and telephone visits with an interdisciplinary team that can provide support and then obviously transfer to hospital as needed. In our first 100 patients, we had only 2 went to the emergency room and none were hospitalized. So remote monitoring is something where I think you can think about it in congestive heart failure, COPD, and COVID, but it could be applied to every problem. And all you need to do is have an opportunity for patients to collect information, transmit it directly to the chart, analyze trends, and make decisions about appropriate clinical care. So in conclusion, virtual is here to stay. The proportion may go down until billing issues are resolved and until we have effective platforms. But the potential will really come from primary care embracing a new role and everyone in the health system working together in integrated teams like Ontario Health Teams. Thank you very much.
Great. Thank you so much, Onil. That was fantastic. Really set the stage and gave us lots to think about, I think, about virtual care and really how much has changed, the paradigm shift in the last few months. It's quite incredible. I see that there's one question in the chat. I have lots I can ask you, but I'll go to the chat first and then see what happens. So Shelley has asked, how does the independent business model prevent an integrated system?
So it's a good question. When I talk about behavior and responsibilities, it's like in the sort of independent business model, what matters is physician autonomy. What hours you work, what patients you take or don't take, where you take them from, when are you required to work with others? Are you required to share your information and your chart with other people? So the independent business models, you've got your EMR, it sits on your server, and you don't need, there doesn't need to be transparency, and you don't need any accountability. In an Ontario Health Team model, in a future state, what you might see is that your chart is available to everyone in the team, possibly everyone in the region, that you share, care responsibilities with others. If you think of that care platform, people may assign tasks to you, you may assign tasks to others, and you have a reciprocal responsibility. And the last thing in a future state for the Ontario Health Team is a capitated model where it's based on value. So every patient has a projected total cost of care or an expected total cost of care. If you come in under that total cost, then the savings would be shared among others. And that would mean family docs actually sharing their funding envelope with home care, with pharmacy, with hospitals, which is something that the independent business model is not ready to do right now.
Great, thanks. And Nancy asked a question, have pharmacists been at the table in the virtual primary care discussions, and how can those on the call get more involved?
So they have been, at least, in-house in family health teams. We've got pharmacists that are very active in family health teams. The virtual approaches have made it quite easy actually for them to do med reconciliation, deprescribing, a lot of the kind of core pharmacy activities. I think community pharmacies have not come on board to the same extent, probably because we don't have easy platforms, like we're on the phone with them regularly. But to say that they are a member of our team and they are contributing directly to care plans, that hasn't been the case. I think there's certainly bridging patients a lot more. I mean, part of the primary care story, which I didn't give, is a lot of places cut back dramatically. Either they were older docs who were concerned about, how to manage this, or folks that didn't have access to care platforms and didn't transition. So access to primary care plummeted, and you guys stepped up. The pharmacy community did a spectacular job, I think, in terms of bridging patients, providing advice. You guys are at the front line. And so, but we didn't do it as a team, right? You guys did that on your own. And I don't want to overstate it, but I think primary care did not step up in the early phases of this.
Yeah, and I think that's something that should come back to the primary care table, the collaborative primary care table, the interdisciplinary table, and talk about this probably as a large group of disciplinary stakeholders to try to figure out how we can work better as a team. Absolutely. Have you been involved in drone delivery of remote monitoring?
I have not, but I think, what we had, so in our COVID at home program, we send pulse oximeters and thermometers, Bluetooth thermometers to the patients in their home, but we just used a courier. We didn't use drones.
No, yeah, that's great. So I was going to ask a question, but I'll ask Zubin's question instead. Has there been any change in the actual nature of provider-patient relationships that you've observed as we've shifted to virtual care in the last few months? Is it more transactional and impersonal and therefore perhaps less therapeutic? Or has that actually mattered? Has that happened and has that mattered?
So the biggest shift I've noted is actually the use of, in primary care, we deal with undifferentiated conditions. Most of the time we can't even diagnose what we see. And so time is an important diagnostic tool. And so because we can't even in many cases, we're not examining our patients, what we end up doing is actually checking in with them every day. And the number of patients that, especially my COVID patients, call them every day for 14 days. And the way your relationship changes when you check in with somebody every day, sometimes for 5 minutes, sometimes for 2 minutes. Yesterday I had a patient who just kind of was discharged from the program. Spoke to him every day for 14 days. And he's like, "Doctor, I'm so grateful that you were with me through this experience. It's super scary. And I knew every day you or someone from your team is going to call me and check in with me." Patients with cellulitis, I get them to take a picture of their, I've got a lady who's sending me pictures every day of her thumb. And I'm saying, "How's it going?" So that actually has been a deepening of the relationship. On the other hand, there are patients who, don't come in, we don't hear from. And for sure that, maybe it has been fraying, but I think we've been relatively good at doubling down on close connection with the people we're most worried about.
And I think, the channel management that you mentioned, I think, is so critical here. You're learning where to go deeper, where to be more regular, what type of modality to use. And so there's so much that I think we'll be learning in all sectors right now, and all with all disciplines through virtual care. I have to say there's lots more in the chat box, so I might not get through all the questions, but I'll do my best for the next few. From Ernie, he's asked, has there been work on research around mapping virtual or digital technologies across the care delivery value chain, from prevention, risk assessment, intervening, and monitoring patients? So just mapping what's needed, I guess, when.
Yeah, that's a great question, and I have not seen that, but that's the work I would love to do. Say, okay, these are all the functions. These are the available technologies. They fulfill, to what extent do they fulfill those different functions? That's a very nice project. I have not seen that to date, but would love to get involved. In fact, we're engaged in a project with the ministry on kind of virtual care post-COVID, and we've got 6 months to lay out a roadmap for the ministry on this.
Great, we look forward to that, to the results of that. I'll take one. There's a couple more questions. We'll see if we can get through them. How big a problem is interoperability of various data systems?
Huge problem. And part of it is like some of the vendors are monopolies, and they're not required to play ball, right? Interoperability or inoperable systems is a good business model. It's a good business model when the transaction costs of switching a platform are high. So you get locked into a vendor, they've got your money, and they don't feel the need to change. So interoperability is a huge problem. That's why we don't have coordinated care platforms the way we would like. It's shifting, it's starting to change, but the ministry has not exercised any, there hasn't been a lot of policy pressure for interoperability. Some of the latest documents suggest it's there, but just to say, it's a big problem, but it's improving slightly.
I'm going to beg one more question, and then we'll move. We'll thank you very much. But I'll ask about proposed amendments to FIPA. So Deb has asked about proposed amendments to FIPA to enable digital health interoperability. How is that and a digital health information exchange policy enabling virtual care? So, do you have a comment on how you see those amendments helping?
I think they are. I think in the early days of the Ontario Health Team model, when you looked at PHIPA, it was like it impedes collaboration. It impedes sharing across institutions and sort of building teams that can integrate, right? So I think the ministry was conscious of that. I remember I was part of the evaluation teams for a lot of the Ontario Health Teams, and it kept coming up. So I think there is some movement on that piece of it, and interoperability obviously is core to that. The health information exchange, I think, a future direction could be, and the states have done this a little bit, is to make patients custodians of their own information and allow them to exchange that information. And then it gets around some of the consent issues. And it's like, the patient's in charge, they share it with whoever they like. And so some platforms like Apple Health allow you to do that. Apple Health's not, widely taken up here, but has spread. I mean, it's only good for a subset of the market, but the concept is sound, and I hope we'll see more of that.
Yeah, great. Thanks, Onil. Thanks to everybody who submitted questions and comments. A fantastic presentation, lots to think about, and really exciting to hear all the things that will come as well from all the work that you and others are doing to help move us along on the virtual platform. And pharmacy, of course, looks very much forward to being part of all of that so that we can create the best interprofessional teamwork for our patients collectively. So thank you so much for sharing your time with us. I'm now going to turn the microphone over to Nancy Waite, who's going to introduce our next set of speakers. Thanks, Onil.
Thanks.
Excellent, and thank you so much. And actually, as we hear from our presenters today, it parallels a little bit what Onil was talking about, was the pre-COVID. We're going to see and hear from a number of groups who were in that virtual space in pharmacy over the last little while. And I think they probably, when this all happened, said, finally, people are interested and want to know more about what we've been doing. But we are also going to hear from some researchers who pivoted, and I know that's a bit overused word, but really did, and really saw the situation for what it was and what needed to happen. So I'm really pleased to be able to introduce the different speakers this morning. Just a reminder, we will be going through all three presentations right after each other, and we'll have questions at the end. what I might suggest is that if you have a question for the speaker, right at the time you're thinking about it, put it in the chat. Why don't we just number our presentations 1, 2, and 3? And so you could just put in presentation 1 or P1, and then write in your chat in the chat box your question. So thanks very much. I'm really very excited to introduce our first 2 speakers, Risu and Michelle Yi. And I've been watching and following MedMe for the last little while. So this is really great to see some of the work they've been doing. Ri is the co-founder and chief clinical officer at MedMe Health, a patient care platform designed for pharmacists to schedule, track, and conduct clinical services virtually, on-site, and at scale. Ri holds a PharmD from the University of Waterloo and previously co-authored 3 nationally accredited pharmacy programs and has worked across oncology, geriatrics, and mental health. Michelle Yi is a 4th-year PharmD candidate, yes, for those students, great, at the University of Toronto, and previously completed a Bachelor of Science at McMaster University. She first joined MedMe Health as an APPE student and is now a clinical associate focused on virtual care research in pharmacy. The presentation today is called Realities of Virtual Care in Community Pharmacy Since COVID-19. And Ri, I'll let you take over from here. Thank you.
Thank you so much, Nancy, for the wonderful introduction. It's our pleasure to be here speaking to everyone. And that was a fantastic presentation to start us off by Onil. And it really does speak to kind of the need for additional research when it comes to virtual care, particularly in community practice. And let's just kind of get started. I wanted to first put a disclaimer that we are affiliated with MedMe Health, and the material in this presentation is also derives from some of our early market research over the last couple of months. So needless to say, virtual care is here and it has been growing rapidly with the catalyst of COVID-19 over the last number of months. And there has been a proliferation of virtual care in primary care, particularly used by physicians. But the challenge within community pharmacies is that our workflow is traditionally different from the scheduled appointment-based models in primary care and the lack of integrated technology that exists. When we look at the ecosystem as well, we also see a number of telemedicine platforms that have come up, as well as partnerships with Shoppers or Rexall when we look at Maple and Tia Health. And when we look at the existence of these platforms, we also see really a gap in pharmacists being able to deliver virtual care in the community setting, despite the proliferation of some of these technologies. And this dismal adoption in community pharmacy is also matched with kind of disparate pharmacy legislations when it comes to virtual care and the lack of clarity around reimbursement, which we'll kind of touch upon later at some of the challenges that we're seeing in community practice.
So at MedMe Health, we wanted to learn more about virtual care and community pharmacy. So this is what we did. We evaluated community pharmacists' uptake and attitudes on virtual care solutions and identified barriers and opportunities to their implementation. How we did that was from the period of March to present day. MedMe Health conducted prospective unstructured interviews with around 306 community pharmacists across Canada. This included pharmacists in Ontario, Alberta, Saskatchewan, and also Nova Scotia. And what we found was, through our conversations, was we identified there was a low interest and uptake of virtual care in community practice, where only 30% were interested in exploring virtual care solutions, and majority still had preference over telephone consultations. Out of those that were interested, only 28% wanted to implement virtual care immediately or within a 3-month time period. Our conversations also allowed us to identify some barriers that was in community pharmacy. The first one being slow and uncertain governing action regarding to reimbursements and legislation. So there have been questions about pharmacy reimbursements for clinical services that are delivered virtually, whether or not they exist, and also the longevity of these reimbursements beyond COVID-19. In addition, there have been unclear and inconsistent guidance and legislation of virtual care considerations across Canada. For example, there are inconsistencies with the requirements for privacy and security, documentation, e-consent, and best practices within community pharmacy. A second barrier was pharmacists are still pretty attached with using the phone. This could be potentially due to the familiarity and convenience with using phone as a consultation method, the lack of equipment such as webcam support, and also the lack of understanding on the value of video versus phone. A third barrier is the lack of tools designed for the pharmacy workflow. This could hinder a pharmacist's interest and ability to implement virtual care within their community practice. And the last barrier is the concern for the older adult population and whether or not they're able to use technologies. Here, I would just like to feature a case study of a community pharmacist in Alberta. Through our conversations, he first started using virtual care as a result of COVID-19. And this virtual care actually enabled him to conduct 300 hours of direct patient care, doing services such as medication reviews, minor ailment prescribing, and weight loss coaching. And he found that this increased accessibility for patients and also increased patient engagement. And I would like to quote, only after using video digital pharmacy solutions did I realize the profound difference between using a telephone and using video. Real and consequential information is absorbed via video call that would not be gleaned from a phone call. The clinician has to experience video calling themselves to realize just how profound this difference is.
Now, in terms of points of discussion based on the results that we found, firstly, there is clear evidence that we need clear guidance and policies on the reimbursement and governance of virtual care. And we've been following the governance closely in Canada over the last number of months. And we've identified kind of the differences in both reimbursement and what legislations that each province expects. And fundamentally, they are quite unclear and require additional standardization. Here, I'd like to highlight Saskatchewan as a province that has been quite innovative, and they actually have funded virtual consultations for clinical services such as medication reviews, smoking cessation, and minor ailments prescribing. And they have actually also funded a specific software platform for all of their pharmacists to deliver virtual video consultations. However, we discovered that there was very low uptake of this platform because it was initially very much designed for the physician use case. Other great examples include Alberta, where the College of Pharmacy actually produced and published a very comprehensive guide that included all the security and privacy aspects of choosing a video platform and provided guidance for their members. Additionally, we also saw here in Ontario that the Ontario Pharmacists Association did also publish a virtual care guide stating some of the best practices to assist pharmacists in virtual care. Another province I'd like to point to is Nova Scotia, as they've continued to extend funding for virtual consults for minor ailments, previously extending it to the end of June and now to the end of September. However, we also see a number of provinces who currently do not provide reimbursements for virtual care delivery, and there just needs to be more consistent reimbursement and governance in this aspect. In addition, when we look at the current tools that exist, there are very few pharmacy-specific tools. And especially when we think about pharmacy practice, our clinical consultations were traditionally quite ad hoc. They were quite walk-in, and we haven't fully embrace this scheduled clinical service model, or a very appointment-focused model when it comes to clinical services. And so it becomes quite difficult when community pharmacies do not yet have the tools to even schedule and remind patients to have and come in for consultations, or whether it's on-site or virtually, and for them to kind of move completely to a scheduled-based consultation format has been very difficult. In addition to that, there are many different tools that they have to toggle between because there is that lack of integration. And so pharmacies that want to deliver virtual care are having to use multiple different interfaces. For example, they have to use one separate tool to actually facilitate the scheduling of the service and another tool to conduct the video call. And this also doesn't include the required government documentation, as well as the necessary follow-up for continuity of care in the midst of all the other tasks that they are needing to do in a community setting, especially with the pressures of having of drug shortages and getting adequate PPE. And so what there needs to be more research and design on is more pharmacy-specific digital tools, especially ones that are integrated into the pharmacy management system, as well as those that are integrated into other healthcare teams like EMRs, where we're able to gather more information about to facilitate a continuity of care. Lastly, virtual care is still a very novel concept in community practice, and there are very evident gaps in both research and education of virtual care. Firstly, we've identified that there is a need for additional training, both for current students and practicing pharmacists in continuing education programs, for pharmacists to actually understand the different terminologies as they pertain to virtual care, digital health, telemedicine, telepharmacy. What are the best practices to delivering virtual care? And what are some of the risks and benefits for their patients and for pharmacy practice when we think about enabling pharmacists to move from the dispensing role to a more clinically focused role? The second part is research on the impact of virtual care on both pharmacists and patient experience. And so from the pharmacist side, we really need to identify the various considerations when implementing virtual care into their local and contextualized workflows, as there is no one-size-fits-all solution when it comes to community practice, especially when we think about the wide variety of differences between rural and urban areas. And this can really help to inform the design of new and pharmacy-specific technologies within virtual care. In addition to this, we also want to identify how this can impact the delivery of clinical services for pharmacists, and how we can perhaps leverage virtual care and other technologies and integrations to facilitate our role as a very clinically focused model of care. From the patient side, there is really the need to really measure the uptake and satisfaction of virtual care provided by pharmacists, especially community pharmacists, and segment this based on locality as well. We also want to determine if virtual care delivered by pharmacists can impact the accessibility to healthcare for patients, whether it increases the delivery of clinical services such as the medication reviews, which can lead to enhanced healthcare outcomes, and whether or not this actually increases engagement of the patient's family and their caregivers by being able to see them in their own home environment. And lastly, we need more research on the impact of patient health outcomes from pharmacists deliver clinical services virtually. And these are results such as improvements in medication adherence, any reductions in adverse events, hospitalizations, and improvements in quality of life. And this also provides an opportunity for pharmacists to leverage virtual care to improve home care, to improve ability for remote chronic disease monitoring, especially when we think about remote monitoring devices and how pharmacists can play a role in that, and how we can facilitate our role in these collaborative and integrated healthcare teams like Onil had mentioned, mentioned, when pharmacists and community pharmacists are able to practice virtually. And lastly, the data from all of this is really important because it will inform our advocacy efforts for payers like the government for both continued funding of virtual care as well as continued funding for clinical services of pharmacists in the community. And I'd like to provide thank you to all of our awesome U of T APPE students, as well as the rest of the MedMe team. And I know we have a Q&A at the end, but if you don't have the time and have additional questions, you can email me at the contact there. Thank you.
Thank you so much, Rhea and Michelle. That was excellent and very interesting to hear how different it is across Canada as well. And the great number of interviews, 300. When I saw that number, I thought, wow, that's a lot of time, but it's really valuable to get that cross-country experience. So thank you. As well, love the fact that you want to be involved in our curriculum. And so we'll be talking, both U of T and Waterloo, about how we can help get this back into our curriculum because we all need better training. So thank you very much. I'll move to our next presentation now. And the next presenter is Dee Wang. Before I do that, just a reminder, any questions you have, P1, put them in for Rhea and Michelle, and we'll get to those later. Do the same. Dee, who's coming up, will be P2. Also, just to the presenters, I forgot to say this, but just when you, at the 2-minute mark, I will come on my video, so you'll just see my face pop up, and that means you have 2 minutes. That maybe help you with time as we continue. And thank you, Michelle and Rhea, for staying on schedule. Dee Wang is an advanced practice pharmacist in primary and geriatric care, and she has experience working in various healthcare settings. I am so pleased she is here today because we have been listening and hearing about Northwest Telepharmacy. They have been doing virtual care for years and waiting for all of us to get caught up with them. So it's really exciting to hear her perspective. She's a hospital telepharmacist for Northwest Telepharmacy Solutions. She received her Bachelor of Pharmacy in 1999 from the University of Toronto, and in 2004, her Doctor of Pharmacy from the University of Florida. Her presentation today is called Virtual Comprehensive Medication Reviews at a Rural Family Health Team in Northern Ontario. Welcome, Dee. Thank you.
Thank you, Nancy. Can everyone see my screen? Yes?
I see it. Thank you.
Okay. All right. Okay. Thanks so much for having us, and I want to say thank you to the MedMe presentation. It really hit home with many of the things that we're struggling with as well, such as integrated platform, as well as some of the compensation for service models. Okay, so I'll start the presentation. A presentation is on a virtual comprehensive medication review program at a rural family health team in Northern Ontario. So this program was provided to Powassan and area family health team. A little bit about Powassan. So Powassan is about an hour away from North Bay. It's a small community. It has about over 12,000 people in the catchment area. The clinic has 5 physicians and a few allied healthcare professionals, such as a nurse, including diabetes nurse, and a dietitian. For our program, they had 2 MDs that were dedicated. Locally, they didn't have an on-site skilled pharmacist that could provide the medication reviews. The program itself involves providing comprehensive med reviews to those who are 55 years of age and on a minimum of 15 medications. Slide. All right, so here's a photo of a screenshot of what you will see on OTN. So I have to stress that all the patients that we saw and performed med reviews were done via Ontario Telemedicine Network, OTN. So just acknowledge this photo was taken, and this is a patient role played by one of our PharmD students, Brian. All right, so in terms of process, patients were telephoned by the clerical staff at the Powassan Clinic and booked the appointments into the Northwest pharmacist timetable. There were 2 pharmacists from Northwest involved for this program. I was one of them, and Dora Chan is the other pharmacist. Each appointment was booked for an hour long, and the patient was asked to bring his or her medications and or medication list to the appointment. The pharmacist met with each patient on OTN and did a comprehensive med review. The pharmacist then documented the encounter along with the recommendations in the practice solutions, which is the program that they use for electronic charting, lab sharing, etc. The MDs would then review the recommendations and provide feedback whether certain recommendations will be implemented or not. Just some findings. So we saw a total of 58 patients over a period about 2 months, around February and March. The average age of the patient was 74 years old. And in terms of average number of medications, as a result, MedRec. So you can see before MedRec, average number was 16, and this number was significantly reduced to 14 after the MedRec alone. And the number actually does not count the type of the medication that were suggested to discontinue after the comprehensive med review. More findings. So we looked at the percentage of patients on benzodiazepines, on opioids, on PPIs, as well as how many people did not need a medication list update. And these are the common family health team quality improvement indicators. That's why they're tabulated here. I just want to point out that although there are 10% of patients on benzo, but when you look at the data more clearly, there were 6 people out of 58 on benzo, for example. Only 2 of them that was appropriate to stop or reduce dosage. For the other 4, they use benzo very occasionally. So for example, when I asked them, one of the patients would say, okay, I use lorazepam 1 milligram for 2 nights when something really is bothering me on my mind, but I don't have to use it for another month or 2. So overall, Powassan population, they're, I think, more active. They're mostly farmers, well off economically, and they do lead a healthy lifestyle. For example, one of the patients that I talked to, he's 82, and he told me that he was going snowmobiling after our med review conversation. More findings. So out of the 58 patients we saw, 71% for 71% of patients, MDs were able to actually comment on our recommendations within 24 to 72 hours, and that was helpful. The average recommendation approval rate by MD was 81%. Of all the recommendations that MD approved, only 2 were declined by patients. As of March, so we did set a date. It's like, okay, this is a date where we tabulate all the results. So as of that particular date, for 11 patients, MD were actually waiting to bring back patients for further assessment based on our recommendations. Again, the MDs were quite, I would say, responsible and detailed. So here's a slide, is a bar graph that shows therapeutic recommendation that occurred more than once out of our comprehensive medication reviews. So as you can see, the top 3 interventions were reduce or stop statins, reduce or stop blood pressure medications, because those patients were identified to have a fall risk. And the third one was taper off proton pump inhibitors. And just give you more examples. So these are the recommendations that occurred only once because of the smaller sample size. We had 58 patients, but it shows you the comprehensiveness of the med reviews that were done. So for example, under stop or reduce a medication, for example, we stopped hormone replacement therapy for elderly female patient. We reduced a apixaban dose. We stopped tamsulosin. For starting medication, we were able to start Singulair for a patient who had uncontrolled asthma, and also added mere background for overactive bladder. Just goes to show you the type of things that can be done over OTN using virtual care. So what worked well for this program? So the clerical staff actually booked appointments for us. The clinic actually has an OTN room, and the clerical staff will help the patient set up OTN connection, etc. That was helpful. Secondly, the staff actually knows the patients well. Most of the staff have been there for 3 years at least, right? So patients were more inclined to book an appointment with us who were remote, and they were meeting us the first time on a computer screen. Patients have a trusting relationship with the 2 referring doctors. That's important because one of the clerical staff actually says, if she says, Dr. So-and-so wants you to come for this appointment, then that patient will come. Another facilitating point is that MD provided timely feedback. The communications were almost immediate. So that helped us as pharmacists to gauge, whether our recommendations were helpful or not. Lastly, Northwest pharmacists involved are quite skilled as well. So we've had, between me and Dora, we've had quite a bit of primary care and geriatric and deprescribing experience. So in conclusion, quality virtual medication reviews are achievable. There's a testimonial from one of the MDs after we saw all the patients. She said, patients received quality pharmacy service that might not otherwise be available in a rural care area. And I have to say, highlighting what Matt Nee was talking about, I think with the increased demand for virtual care, the capacity will be enhanced by having integrated e-platform. I think lastly, I do want to acknowledge my team, the physicians at the Powassan Family Health team, for giving us incredible support to have this program successful. Thank you.
Thank you so much, Dee. That was really great. Loved hearing about a community that probably many of us haven't visited, but know are many in the province. But also to see the MD response that you had to the program and how integrated and welcome it was and timely they were, and really great to see. So thank you very much, Dee, for your presentation. Again, I will invite the participants to put in your questions into our chat. And Dee is P2. She's our presentation number 2, and I'm really excited to have some questions, and I have lists already going in my mind for all our presenters so far. So thank you very much, Dee.
Thank you, Nancy.
Right, we will move to our next presenter, and I'll let Stephanie get her screen up and shared. So Stephanie Ong has received her Bachelor of Pharmacy from the University of Toronto, and she has graduate training in a very interesting area, health informatics, from the University of Victoria. And I certainly see our students having more interest in getting training in this area. Of course, we need to put more in our curriculum, but we are beginning to have a number of pharmacists asking how can they get more engaged. So Stephanie, thanks for alerting us to one of the places that has a health informatics curriculum, but there's many programs out there. She's a clinical pharmacist in nephrology, one of my favorite areas, with the University Health Network, and her main research interests lie with developing and implementing digital health tools for patients and enhancing medication management service delivery. She currently leads projects with the Division of Nephrology for the development and evaluation of digital tools for patients with kidney disease. Her presentation today is called Resolving Medication-Related Problems Using an Integrated Mobile Application to Bridge Patients and Pharmacists to Support Virtual Pharmacy Care. Thanks very much. And Stephanie, I'll let you take over your slides. Thank you very much.
Thank you, Nancy, and thank you to the group for having us today. I am quite humbled to be in this space and excited to hearing all the presentations, a lot of learning and sharing, but also quite grateful for inviting me today to share some of the work we have done in virtual care and also some of the results that we kind of can provide impact in pharmacy practice. So to begin with, in this segment, what I hope to describe is some of the mobile app work that we have developed and implemented and also evaluated in our chronic kidney disease population, and also related to how it's being used to support medication management. I would like to also present some of the results in our pilot study and share some of the highlight key findings that we found in the clinical trial that followed thereafter, to show some of the significance and also the implications that we can use from the learnings from these trials and the value of integrated mobile apps in virtual pharmacy care. So to begin with, I want to share some of the motivations that we had in developing this platform. As we know, patients with complex chronic conditions like kidney disease are on numerous medications. They are high risk for medication-related problems. They see multiple physicians, between 2, 3, or 4, and transition frequently between healthcare settings. The consequences of these medication-related problems are high ER visits, hospitalizations, and it's very costly to the healthcare system. We do have ways to address these medication-related problems, but we also know that there's gaps. And these gaps are process gaps and also many gaps between the stakeholders that are involved. Processes such as medication reconciliation or comprehensive medication reviews that occur in pharmacies do exist, but we have noted that they are very resource intensive. And it has also been cited that it has been a frustrating process, not just for us pharmacists, but also for our patients we serve, because we cannot maximize our roles we cannot play an effective player in the medication management process. Digital health tools may be able to address these gaps, but most of the medication-related apps or tools out there that are present or consumer-driven mostly function as logs, diaries, pill reminders, or drug information resources. So the ones that are readily available for patients focus on these. So particularly for patients with complex chronic disease like kidney disease, both our patients and providers, like pharmacists, need dynamic and collaborative tools to review and update medication-related information so we can effectively communicate and participate in the process. So this is what really helped motivate and drive the development and implementation of an integrated mobile app platform. We set out to address these limitations and develop the eKidneyCare mobile platform that was built on a feedback system and really integrated patients with their providers. The eKidneyCare mobile app platform is designed to integrate at 3 different levels. The first level of integration is with the patients and the device level. Patients can pair their smartphone with the preloaded app to Bluetooth-enabled peripheral devices, such as a blood pressure device, to allow for seamless data transfer, eliminating the need for manual data entry. At the systems level, a central server connects the smartphone to the server and to data repositories such as lab repositories or medication repositories to provide patients and providers the same information and real-time access to this medical data. At the clinic level or the clinician level, health professionals such as physicians, nurses, and pharmacists within the team are then alerted by algorithms when predetermined thresholds are met and crossed, and they have access to the data so that they can intervene early and when necessary. All these processes are fully automated, algorithm-driven, and patient-specific. Alerts are also tiered so that the action messages to either the patients or the providers are delivered in real time, but also it takes into account the workflow that each of us are encountering in our day-to-day lives. The smartphone application for patient consists of 4 key behavioral components that have been shown to have clinical impact in chronic disease management. They include blood pressure monitoring for the ones with chronic kidney disease, medication management, symptom assessment, and access and tracking of key laboratory results. But all these behavioral components really focus on two foundational elements, which is having a connection with your care team and also having access to personalized health information through educational resources. On the other side of the platform is your clinician dashboard. So clinicians such as physicians, the nurses, the pharmacists on the team have access to a web-based dashboard where all the medical data sent by the patients are summarized. Clinicians are receiving alerts in real time that are tailored to their scope of practice. So physicians will get their own alerts, nurses will also get their own alerts, and pharmacists will get their own specific alerts. But they have all the summary and historical trends to be able to conduct their own specific work or day-to-day routine based on the summary of other medical data that is there or available to support these interventions. Any type of critical alert that needs immediate action are sent via secure email. This web-based dashboard essentially provides an overview of all the alerts, summarized reports, and historical trends for all the parameters. The clinicians use this to daily review their patients and how they're going to act and intervene based on the level of alerts sent. Specifically with the medication management module, which is what I want to focus on today, what the patients see is that they have an access to an up-to-date medication list, and monthly, they are then recommended or reminded to review their medications or as needed. When they review their medications monthly, they answer 3 directed questions: whether there's something new that has occurred, whether there's changes, or if they're having any issues or problems with their medications. These responses are then sent as an alert to the pharmacist. Pharmacists receive the alerts. When the patients report any changes, the pharmacists are then triggered to intervene by calling them or emailing them with the patient to review their responses. All the parties have access to this up-to-date list, whether you're a patient, the pharmacist, the physician, or the nurse. And every month, or when the patient feels like they need to review or contact their team, they press the review button. This collaborative medication management process really lies on the integration of the app into the central server, then to the clinical team. The identification of medication changes between the visits lies on the live interface that occurs between the smartphone app to the data repository that hosts the medication database. The bidirectional transfer of medication-related information between the patient and the pharmacist and vice versa is facilitated by algorithms. So all these alerts are tiered depending on the level of whether it's critical, something that is just cautionary, or something that does not need an intervention. At this point, as we know, medication management then becomes a collaborative effort. So the patients can play their role in reviewing their own medications, but also have the ability to communicate back to the pharmacist if things go wrong. And then 2 parties can communicate back and forth with the support of an integrated platform, because pharmacists, on the other hand, will receive alerts, but it's based on algorithm, so that's efficient and it's effective. So we moved on to try this app and evaluate it in our patients with kidney disease, and started off with a pilot in 2016. We wanted to evaluate the acceptability and feasibility of using the app in advanced CKD. So these are patients with advanced CKD, so stage 3, 4, and 5, but not yet are on dialysis or transplanted. So we involved 47 patients in our clinics at the University Health Network in over a 6-month period. What we did see is that at the end of 6 months, we also saw a change in blood pressure in all our patients, and especially in the ones with uncontrolled hypertension. But more importantly, what we saw was in the medication management section. What we found was a remarkable identification of over 100 discrepancies that were reported from the patients. And 49% of these discrepancies were clinically significant enough that they required an intervention from a pharmacist to prevent patient harm. What we also saw was that patients were able to adhere to using the mobile app throughout the 6 months. whether it was blood pressure monitoring, monthly medication reviews, or symptom assessment, they were able to exceed the minimum requirements for monitoring or reviews in over 80% of the time. And their use and behavior was sustained throughout the pilot study. This is significant because in the mobile app space, especially in digital health tools, there tends to be a decline in the use of mobile apps in the first 3 months to less than 10%. We download it, we play around with it, and then we dump it after that. But in these patients, it was actually sustained, and they were quite engaged in using it and reporting back and forth to our clinical team. Especially that the average user or patient population that were actually enrolled in our pilot study were over the age of 64, and they reported when they were enrolled that over 60% of them never owned a smartphone or never used one prior to the pilot. The highlight cases that involve the medication discrepancies I'll describe in this slide are some discrepant doses with diuretics from what was recorded in the chart, adverse effects that were reported due to dizziness after an increase in blood pressure medication, medication adherence where patients reported that they never filled the medication or did not take it because they didn't think that they were supposed to continue a chronic medication, or medication errors where NSAIDs were prescribed to patients who had advanced kidney disease and were not supposed to receive it. So with this app, pharmacists were able to identify it and intervene early to avert any patient harm. So we then moved on to a clinical trial that recently completed, and we evaluated the mobile app in terms of comparing it now to a standalone app that is readily available in the market space. So in this clinical trial, we compared the use of eKidney Care to MyMedRec, which is a standalone app, and sought to see what it does or the effect on medication discrepancies. In this, we saw that 182 patients were enrolled, and the primary outcome what we looked for was medication management, and secondary outcomes were economic analysis and user acceptance. What we saw was that when eKidney Care users used the app for 12 months, they experienced almost 50% of fewer medication discrepancies than MyMedRec. We did not see a change in blood pressure or lab results after 12 months. And when we looked at the cost, we looked at app costs in setting up and using, the time it took for pharmacists to intervene, the med errors that were addressed, and healthcare use. We saw that the use of eKidney Care was more cost-effective than MyMedRec when we look at from health systems perspective in terms of hospitalizations avoided and medication errors addressed. And there was approximately $200 cost approximation of investments that is needed to avoid one CKD-related hospitalization, which will amount to about $13,000. User acceptance was also high and maintained throughout the 12 months. So this was really highlighted, and the clinical significance of these discrepancies of what we saw was that eKidney Care users also showed that 60% of them had a lower incident rate of severe medication discrepancies that can cause severe patient harm. So what this shows us is that early interventions by pharmacists that are triggered by alerts because of the regular reviews by patients using the mobile app can really reduce the severe medication discrepancies to prevent adverse drug events. The implications in virtual care are high because when face-to-face visits with pharmacists are restricted, and as we know, it's really difficult for us to do comprehensive medication reviews, the role of the patient is equally and even more so important. However, they need the tools to be able to effectively communicate with their pharmacists, and pharmacists themselves need tools to be able to efficiently triage and also work through all these complex patients. But at the same time, this is a partnership between the two individuals that are part of this process. And we need tools that allow us to consolidate all this data, integrate it into one platform, and also to allow to seamlessly and securely communicate with one another so each of us can play a maximum role in the process and avert medication-related problems for these patients. This is the great team that I work with in development, in implementation, and also in research. And I thank you for your time and open it up to questions.
Thank you so much, Stephanie. That's really interesting. Again, all of these talks are really making me think about all the different aspects of technology and virtual care and how we do this. But this was really interesting to see the interprofessional approach to it. Really interesting to hear that many of these older individuals had not used smartphones before. Love seeing the integration with monitoring devices and so on that we've been talking about in our first presentation, and also the economic analysis. So Stephanie, a lot of really great points. Thank you very much. Again, I will ask that if you have questions for Stephanie, and I know a few have been coming in, so this is great, just please put in P3. And at this point, I'm going to turn it over to Annalise, who is going to moderate the question and answer periods. Thanks very much.
Thanks, Nancy, and thanks to our group of 3 presenters. We've gotten quite a few questions for each of you, so I think I'm just going to go one by one and kind of go through the questions and try and separate them out according to presenters. So maybe for Ree and Michelle, we have a question from Shelley. She asks about the community pharmacy survey, and she says, were you asking if the pharmacists wanted to provide virtual care themselves or if they wanted to hire a company to provide virtual care as an outsourced service?
Absolutely. So when we were interviewing pharmacists, they were mostly independent pharmacists out in the community. And we were asking, what are some of the barriers that they were experiencing right now, what their attitude towards virtual care, as well as whether they'd be interested in having a virtual care platform to provide the virtual care. So it's not as an outsourced service for another pharmacist to come in and in terms of the attitude towards that, there's a lot of contacts that the individual community pharmacists have with their patients in their community that they want to maintain that relationship and for them to continue delivering that themselves.
That's great. Thanks, Ree. Maybe we'll move on to a question for Dee now. This question, did you find out if patients were in agreement with your suggestions before making them to the prescriber? And would that be an enabler as well?
Yes. So every time we make a recommendation, we tell the patients the type of recommendations that we make. And included in our recommendations, we will actually say, for example, suggest reducing statin to 5 milligrams once a day, patient in agreement, or patient is not sure. So we do include the patient's attitude. I guess this is related to 2 patients declined. So we didn't know that those 2 patients were not too excited with stopping. I think one of them was the statin stop. And the physician still asked, because sometimes patient's attitude or report with the patient may be a little bit different, and they then documented for us that patient still declined. Yes.
Okay, great. Thank you. And Stephanie, we have a question for you. Maybe you can expand on this one a little bit. Shelley says, I wonder what a system would look like that can use tools specific to certain chronic diseases, as well as take into account the multiple chronic diseases that a patient could have. So looking at overall chronic disease management, all medications, and or health and well-being.
Yeah, so some of the work that we've also been doing, because our patients don't just have kidney disease, they usually have overlapping conditions, 2 to 3. Similarly, there is at UHN, there is also an app called Medley Heart Failure that's dealing with heart failure patients right now that follows the same component. But if you look at the overlapping disease, there's usually those 4 components that I've spoken about: blood pressure, medication, symptoms, and labs. Those are really core to chronic disease. And the physiologic monitoring, whether it's blood pressure, weights for heart failure, blood glucose for diabetes, those are just can be added modules into the platform. So that's the next step of where we see the mobile app space, or for complex chronic disease or multiple chronic disease, where we're headed towards. And there's been work that's being done right now on this.
That's really exciting.
Yeah,
great. We'll go back to the top. Another question for Ree and Michelle. This question is from Marina. She asks, in gathering interest of community pharmacists in providing virtual care, was the information gathered from only family health team pharmacists or also those practicing in community?
So, like I mentioned earlier, our results were from community pharmacists, particularly those who were working in independent practices, so in independent community pharmacies.
That's great, thank you. Back to D. Question from Catherine. She asks, can you tell us a little bit more about collaborating with prescribers and other team members whom you've never met in person? This is a really good question. Did you have a meet and greet before getting started? And did you experience any barriers in collaborating remotely?
That's a good question. So to start off, we did have a meet and greet online, a Zoom meeting with one of the physicians and also the family health team managers, as well as the clerical staff. I believe every 2 weeks we had almost like clinical patient rounds, just sort of chat about patients as well. I think initially we were thinking of even doing a site visit, but unfortunately because that was the beginning of COVID and that didn't happen. In terms of challenges, I would say this is one of the best practice models, Powassan, in terms of delivering pharmacy care. For other remote areas, we do provide services, and I have been told or experienced that sometimes physicians do not even respond to recommendations. But Powassan, we were quite impressed by the timely response and how involved the physicians were in terms of responding our feedback. I think there's a last question about, do we help with the implementation? We actually do not need to because the physician will write back and say, for example, stop LASIK, stop statin, blah, blah, blah. And we will go into chart and we'll look, and actually physician has delegated this task to the clerical staff, and the clerical staff has faxed the prescription to the pharmacy. There were a couple cases where it was more complex, and so we actually thought it was necessary for us to call to ensure this continuity of care. But simple things, and because we were paid by time, our consult services, so when something we thought it was straightforward, that can be delegated by clerical people, we didn't get involved.
Okay, thanks, Dee. Swinging back to Stephanie, I think we can finish up the questions, get through all of them. So Stephanie, this question is from Greta. She asks, how did your team measure prevention of hospitalization due to CKD?
So the hospitalization numbers were done as a part of the cost effectiveness analysis, but a full-blown cost effectiveness analysis was not completed because of the small sample size. So what our health economics team did was a cost modeling based on the 182 patients and looked at hospital admissions during the 12-month period, their ER visits, their clinic use, the number of times they called the nurses, the pharmacists, and all of those worked into that model, and then compared it to the cost of setting up the app and sustaining it, and also the time it took to actually go through the interventions. So all of that combined were put into the model to determine the hospitalizations prevented in a bigger scale.
One last question for Rhee and Michelle. This question's from Nita. She says, interesting presentation, thank you. Have you considered process and journey mapping with community pharmacists and technicians to determine where and how virtual care would fit into their workflow and experience?
Thanks for this question, Nita. This is a wonderful question, and I'm a huge nerd when it comes to journey mapping and design thinking processes, as they have worked so well in other professions, and it's time for us to own that, especially within community pharmacy. As we look at virtual care, it's really in reimagining how our workflows can change to leverage these new technologies so that we can become more clinically focused in the community. And this is a core part of what we do here at MedMe, is in really understanding the current workflows, barriers, challenges, as well as opportunities with each pharmacy that we engage with, and identifying how can we best fit our solution to their workflow so that it's the lowest barrier to entry, but also the most engaging to their patients. For example, it's considering whether or not it's a text or email notification, at what time sent to the patient to maximize the reminder ability and to decrease the number of no-shows. But also when we look into the future, we're not just designing for the virtual care of today, but also the virtual care of the future. Because if we think about interoperability and being able to connect with all these different devices that are maybe patient-driven or digital health applications, digital therapeutics, and bringing all that data to the forefront for the community pharmacists to be able to access and provide clinical interventions on. That's kind of how we're thinking about both journey mapping, what currently exists in community practice, their current workflow, but also thinking about how we can fit in with the greater ecosystem of digital technologies that are bound to be proliferating in the next couple of years.
That's fantastic. Thank you so much. So I think we'll wrap up maybe with one more question for Stephanie, and then we'll take a quick little break. But Stephanie, I'll just ask again from Nada. She says, thank you for your comprehensive presentation. Did you look at alert fatigue on the provider side?
So yes, as part of user acceptance and satisfaction, which was the third outcome that we were looking at, we also looked at the impact on workload to be able to iterate the workflow integration for all clinicians, whether it's physicians, nurses, and pharmacists. So we did look at alert fatigue, and one of the comments after the 12 months was the amount of alerts that happened after the pilot was a little bit too much. And based on those feedback, we then refined the algorithm even further. And that helps with the decision algorithms that then further determines the levels of alerts that each of the clinicians receive. So it's not just the pharmacists, the nurses, and the physicians that feed back into this.
Great. I'm going to sneak in one more question because it's a follow-up from Greta. She asks how the team found out the baseline hospitalization rate from CKD. That'll hopefully be a quick one.
We basically borrowed that from the literature. So all of those cost modeling analysis were determined from the literature.
Okay, perfect. Yep, that was a quick and easy one to end on then. Great. So I'd like to say thank you again to our first set of 3 presenters. I think we're going to take a quick 5-minute break so everyone can run to the bathroom, get a quick coffee again, and then we'll be back at 11:05 to start with our second group of presenters. But thank you again, everyone. This is really exciting so far. Hi again, everyone. I hope that everyone had a chance to grab a coffee and have a little break. I think we'll go ahead and get started with the second half of our presentations. So Sherilyn, if you're available, I will pass the virtual mic over to you to do our introductions for the second half.
Of course. Thank you very much for having me. I'm happy to introduce our speakers for the second half of the sessions. So first up, we have Sandra Veljovic. She is a pharmacist working in an interprofessional pain and addictions clinic at CAMH and is a new grad with an interest in opioid use disorder in the context of chronic pain. Her presentation today is called Changes in Pharmacist Assessment and Patient Care Delivery within Interprofessional Pain and Psychiatric Disorder Clinics during the COVID-19 pandemic. So handing it off to Sandra.
All right, thank you so much, Sherilyn, and thank you to all the other presenters for your very compelling and interesting presentations. I feel like I've really learned a lot already. So yeah, I'll be presenting on behalf of 3 pharmacists working in 2 interprofessional pain and psychiatric disorder clinics at CAMH in Toronto, and I'll be sharing our experience with adjusting how we provide clinical care amidst the COVID-19 pandemic. We have no corporate interests or funding to disclose. So I'll start by providing a bit of a background on how our clinic operates and sort of the typical patient population that we see. So our patients are referred through TAPME or through third-party insurance. So TAPME stands for the Toronto Academic Pain Medicine Institute, and this is a comprehensive interdisciplinary academic pain program that serves as a hub for chronic pain care in Toronto. And CAMH is one of the 5 participating sites in the program to which clients can be referred. We also see clients referred through third-party insurance payers for assessment. And our patient population has chronic pain with concurrent mental health disorders and are typically quite complex from a medical and psychosocial perspective. Usually by the time that the patient has been referred to us, they've potentially seen multiple other specialists and even other pain clinics. And for this reason, they really benefit from an interprofessional team approach and a collaborative model of care. So once they're booked in, the patients attend a full day of in-person assessments with a pharmacist and other team members, such as an occupational therapist, psychologist, and physician. And we work together to produce a comprehensive integrated care plan. And some examples of what pharmacists might recommend in this care plan are listed here. So deprescribing of medications, opioid rotations, and inpatient withdrawal management. The team will then debrief with the patient to review their respective recommendations and provide education as needed and answer any questions. And then this care plan is then sent to the referring clinician, and team members will follow up on interventions that are implemented on an ad hoc basis. So here I'll delve a little bit more into detail about what the pharmacist's role is during that 1-hour assessment that we do. So we will review the current medication list and of course ask about indication, efficacy, safety, and convenience of each medication. We try to identify any barriers to the clients taking the medication, such as cost and adverse effects, as well as screen for any interactions. We review past medication trials, how they took those medications, and determine whether therapeutic dose was achieved. And very importantly, we assess for adherence through physically doing pill counts, and we use that to screen for aberrant drug-related behaviors. And we will often use a urine drug screen to corroborate this information. And those urine drug screens, because the patient is presenting in person, they'll be done on site the day of their assessment. Once our assessment is complete, we'll come up with a list of recommendations for the referring clinician, some examples of which I've mentioned before, and we'll also, for example, dispense naloxone kits if the patient is being seen in person. And then in terms of follow-up, for any medication changes that are implemented, we will provide monitoring for efficacy, safety, and convenience. And we will support the primary care provider or referring clinician as needed. So for example, if we've made a medication change that we've been prescribing from our clinic, we will help facilitate transfer of that prescribing back to the referring clinician. And I'll also mention that we have other responsibilities within the clinic, such as answering drug information questions for colleagues and giving in-service presentations, just as an example. So our objectives today in this presentation are to describe our experience in adapting to providing care virtually and comparing rates of missed appointments between March and June of this year compared to 2019 to assess whether switching to virtual care has impacted attendance at the clinic. So after mid-March, our clinic moved from doing in-person assessments to video conferencing platforms. So one clinic uses OTN, or the Ontario Telemedicine Network, and another clinic uses WebEx. However, in some instances, assessments were done over the phone as patients did not have access to necessary devices. So overall, switching to virtual care has been successful from our perspectives, and pharmacists quickly adapted to video conferencing platforms. And when we compared the rate of missed initial appointments or no-shows during March and June of 2019 compared to 2020, there were similar rates with comparable volumes. And actually, we found that the rate of missed appointments decreased from 25% to 19% over the same time period. And we felt that this was very encouraging and sort of validated the fact that the switch to these platforms was successful. In terms of some of the challenges that we faced, so missing collateral information was a difficult challenge. So physically being able to do a pill count in order to assess adherence and screen for aberrant drug-related behaviors, as well as performing a urine drug screen, which was easier to collect when the patient was being seen in the clinic rather than sending a requisition. So in light of this, we found ourselves relying a lot on communication with community pharmacists and using medication dispensing records as collateral. Another challenge was troubleshooting technological issues with patients, as we were usually the first assessment of the day, and as the first point of sort of virtual contact with the patient, we were responsible for setting up the meeting and ensuring it goes smoothly from a technological perspective. And from the patient side of things, one of the patient barriers, when considering the social determinants of health of our patient population, not everyone has access to a device, and we therefore had to be flexible in some cases in allowing phone assessments. What were facilitators to a successful transition were clear organizational policies for so for example, having clear guidance from the institution on what platforms were best to use from a privacy perspective. So we were explicitly instructed that WebEx was more secure than Zoom, and that's the platform that we used. Another facilitator to the transition was having technological support. So for example, having admin support, as we got more used to the virtual platforms, our admin team would set up the meeting with the patient 50 minutes prior to when their meeting is supposed to start. So that way, our time during our pharmacist assessment wasn't decreased with us just trying to do those like IT issues. And I just wanted to take this opportunity here to provide a concrete example of an initiative that we've started in our practice since the pandemic started. And this is initiation of buprenorphine naloxone at home rather than in a supervised setting. So as I mentioned earlier, our patient population is quite complex, and we see a lot of concurrent chronic pain and opioid use disorder. And buprenorphine naloxone is first-line treatment for opioid use disorder and also has benefit for pain, and it's a very common intervention that we do. Given the pharmacology of buprenorphine, there is a risk of a phenomenon called precipitated withdrawal when it's initiated in people taking other opioids, and this can be very, very uncomfortable and traumatic for the patient. So we do everything in our power to avoid this, and for this reason, we prefer to start it in a supervised setting, such as an outpatient clinic setting or an inpatient unit based on the patient's needs. However, in light of the pandemic, for various reasons, patients were either unable or very hesitant to come in. For example, obviously risk of exposure to the virus, but also childcare needs, etc. So we saw this as an opportunity to provide virtual care by initiating buprenorphine naloxone at home. So we would choose appropriate patient candidates who were typically patients who had strong supports at home and absence of cognitive impairment, and were usually on a relatively low dose of opioids, although we had one patient who was on methadone and was successfully rotated to buprenorphine naloxone via special protocol. And just to go into sort of what that protocol is, the patients were sent a prescription for a supply of buprenorphine that could be picked up at their pharmacy, and they were oriented to the process of the home induction by the pharmacist prior, and were given instructions explicitly on when to discontinue their opioids over the weekend. They were provided education on the rationale for that, and overall prepared for the process that would be starting on a Monday. So on a Monday morning, a team member will call the client or the patient at around 9:30 to assess whether they're ready to take their dose. If yes, the client or the patient takes the dose, and they are called 2 hours later to assess for withdrawal, pain relief, and side effects. If appropriate, another dose is administered, and this process is repeated another 1 or 2 times. The full daily dose that the patient took that day is then consolidated for the next day. And again, prior to when they take their dose, the pharmacist will call them, assess whether it's appropriate, and then provide ongoing phone calls as needed that day. And for the rest of the week, Wednesday, Thursday, Friday, the pharmacist would call at least once a day to assess for, again, withdrawal, pain relief, and side effects, and make recommendations on dose titration to the prescriber. So again, I just wanted to highlight this example as something that, to Lisa's point at the beginning of this conference and kind of what's been an ongoing theme throughout, this was born out of necessity, doing these virtual care interventions, but it's potentially something that we may continue to do once pandemic precautions are lifted. So in conclusion, overall, our experience has been very positive, and this has been validated with objective measures such as improvement in missed appointment rates when comparing the same time period this year to last year. Some of the challenges we found were missing collateral information and lack of patient access to teleconferencing platforms, but facilitators were clear organizational policies and technological help. And moving forward, we may consider virtual care as perhaps a standard of care for client or patients in remote locations to allow for equitable access, and some of the specific interventions, such as at-home buprenorphine initiation, may be something that we continue to do once things return to quote-unquote normal. And that's it from us. Thank you so much, everyone, for listening.
Thank you very much, Sandra, for your very engaging presentation, for describing your practice setting for us and the findings that you've had in making this transition. So once again, for people who are wanting to ask some questions, we'll follow up with Nancy's approach to the first batch. And if you can put P4 in front of questions for Sandra, because we had 3 presentations before the break and she's now the 4th, that will help Annalise with sorting through the questions at the end. So let's move on to our second presentation for this second session. I'd like to introduce Maria Marchese. She graduated from the Leslie Dan Faculty of Pharmacy in 2015 and completed a hospital residency at Kingston General Hospital and went on to practice in both community long-term care and inpatient hospital settings for 3 years in Thunder Bay. In January 2020, she moved to Toronto to pursue a Master of Science in Pharmacy in her clinical area of interest, which is adult oncology. She's currently working under the supervision of Carlo DeAngelis at Sunnybrook Odette Cancer Center and has been working remotely and virtually since March of 2020. Her practice interests include integration of pharmacists into oncology care teams, and her research projects involve perspectives of patients and healthcare providers about medical cannabis. Her presentation today is up on the screen for us, and it's called Delivery of Virtual Clinical Pharmacy Services at Odette Cancer Center, Development of a Process Map. So I'd like to hand it over to Maria.
Hi, everyone. Thank you for the introduction. My name is Maria Marchese. It's a pleasure to be here and learn about all the great advancements we've seen across virtual care in so many settings. On behalf of our team, I'll be presenting the delivery of virtual clinical pharmacy services that we implemented at Odette. And we also made a process map to represent the changes. And I'd like to recognize the others at Odette Cancer Center, Mark Pasetka, Alia Thauer, Blaise Charbonneau, my supervisor Carlo, and Christine Pershing for their contributions in this work. So we do not have any corporate or financial conflicts of interest to disclose. So the Odette Cancer Center is an outpatient regional cancer center located at Sunnybrook Hospital. Our clinical pharmacy team consists of 2 pharmacists and approximately 3 to 5 pharmacy students. We perform comprehensive patient assessment on all new patients who begin intravenous systemic therapy or anti-cancer therapy, about 11 new consults per day. This includes collection of the BPMH, providing patient education about symptom and toxicity management, and resolving any drug therapy problems regarding supportive care medications. And we also have a routine follow-up implemented. We also have an outpatient pharmacy that dispenses a lot of the supportive medications. Several guidelines have been published providing guidance on how to optimize the delivery of systemic anti-cancer therapy during the pandemic. These include choosing oral agents rather than intravenous, where efficacy and safety would be comparable, choosing regimens with less frequent dosing, so spread apart more, when the efficacy and safety would be the same, and delaying surgery where appropriate, favoring neoadjuvant treatment over adjuvant. So favoring neoadjuvant treatment used to shrink the tumor prior to surgery would be a strategy that aims to free up critical care in inpatient beds while continuing to provide outpatient treatment. You'll notice that there are not specific guidance towards delivery of direct patient care clinical services, such as providing medication education to patients, although we have heard a lot today about some of the unique ways we've done this. With implementation of institutional COVID-19 protocols, we had to take the message that was really behind these oncology treatment recommendations, and essentially that was reducing patient contact. And so these protocols were enforced through visitor restrictions, physical distancing, and with PPE. We had to think about how we would apply this to maintain our set of services that we provide, but in a virtual environment. So our clinical coordinator, who's Mark Paseka, took the lead on developing the virtual pharmacy model. So first, we had to define the set of clinical pharmacy services that we would consider absolutely essential and that must be maintained, such as collection of best possible medication histories and drug interaction checking of supportive medications. We then reviewed our complement of staff and student roles within the pharmacy department, considering that some would be working remotely. Visio Basic was used to map out the new processes and outline roles and responsibilities of each pharmacy team member. Then the draft process was reviewed with the clinical pharmacists and students, and feedback and suggestions from frontline staff were taken into consideration. Really, within a matter of days, we had this up and running. Of course, once we discovered what was working or what could be improved, minor adjustments were made along the way. So this is our baseline process map for the delivery of clinical pharmacy services before the pandemic. So all new systemic therapy patients or those who had changes in supportive care medications would be seen on the day of treatment by either a pharmacy student or a pharmacist to collect the BPMH, and this was done in person. We would identify and resolve any drug therapy problems, devise patient-specific monitoring plans, and develop a calendar schedule explaining the take-home medications for the patient here. We also had a built-in follow-up program on days 2 to 3 of the cycle where we would call patients, and this service was already being performed remotely in most cases, and this was for streamlined to moderate and high emetogenic regimen patients. And so as you can see here, all this is occurring in person except for this final step, and we also counsel the patient on the day of therapy. So in the next slide, we're going to outline the changes made to map out our virtual care model. So here's the process map for the pandemic virtual care model. It looks a little more complex, and it is because we're essentially shifting and inserting an entire new workflow into our process. In the new model, we started our process on day -1. This is the day before chemotherapy treatment. So here, a pharmacist or pharmacy student would contact the patient the day before and collect the best best possible medication history, and the entire workup of the patient and preliminary education about the chemotherapy toxicity management was provided in advance as well on this day. So all these steps were performed contactless, where we could implement them. So the patient in this model would generally receive counseling on supportive medications with their dispense from the outpatient pharmacy. And we maximized where this counseling could be done without direct patient contact. We had arbitrarily selected a cutoff time of 2 p.m. As a decision point for phone counseling to better align with our operating hours. If patients were finished by 2 o'clock, they would be usually called at home for counseling on the new medications once they had returned home with their medications in their hand. If patients finished after 2 o'clock, an on-site staff member would usually take care of the counseling either during their infusion or immediately after, because waiting until the patient would return home would be after staff hours usually. However, the pandemic opened up some flexibility in working from home. So for example, any consults I did were on flex time, and for continuity, I usually counseled patients in the evening when they were at home with their caregiver, who would also request to be there for the counseling, because 2 ears are better than 1. So I just want to explain here sort of how we're trying to develop our decision framework for if the patient was thought to be a poor candidate for a virtual consult. So largely this was based on pharmacist judgment, or the patient may have requested to see the pharmacist in person. And so this was accommodated by on-site staff. Typically, the most common reason for receiving an in-person consult was due to a language barrier or requiring translation, because we do have some other languages on site that we speak, and or patients who seemed confused when we started talking to them on the phone. Finally, we did most of our follow-up cycle on day 2 and 3 as well, and so we maintained that over the phone. If I were to comment on the workflow of this, I would say that overall we required a high degree of communication between our remote and on-site pharmacists just to coordinate a smooth experience in terms of provision of the supportive medication calendars, specific patient instructions, and making necessary changes with the oncologist, and just knowing whether the patient needed counseling or not and what stage they were at. So I would have to say the team was very attentive to working together, and I'm proud of our success that we had. Just to give you an idea of how many patients receive virtual clinical pharmacy services, we have this chart here. We started tracking March 25th midweek, which is 2 weeks after the pandemic was declared. And the data collection period here till May 1st aligns with the peak of the pandemic. So over this 2-week period, we had 202 patients requiring a BPMH, and we were able to complete 74% of these altogether virtually. As you can see, the counseling, the numbers were a little bit lower for what we were able to do virtually. But as you can see, this number progressively increased over the 6-week period as we became more proficient in our process. As I had mentioned previously, phone counseling is not always appropriate, and there's not a lot of literature to guide this consideration for virtual care delivery. We're dealing with chemotherapy with significant toxicities and dispensing a number of new medications for the patient, anywhere from 3 to 8 new medications on the day of treatment. So this can be very overwhelming, and we need to be confident that the patient understands the medications and how to manage the expected toxicities. I'll just speak a bit, because video interaction is one way to simulate an in-person experience and provides additional nonverbal cues, enables some degree of physical assessment. It may strengthen the development of a rapport with the patient. However, I found that there are limitations with the accessibility of technology in general. Although I was set up with OTN, and so this was only as of April 19th, so just in these last 2 weeks, I did offer this service for my virtual consults. And out of the patients who were offered OTN, only 2 patients during this above period till May 1st received video counseling. And altogether, up until May 15th, I was able to see 5 patients with video. So this is just a summary. So overall, we were able to increase the number of BPMHs completed virtually from 67% in the first week to almost 80% in the last week being done virtually. And counseling also rose to 56% in the final week. So our next steps, since the need for a virtual clinical care model may need to be extended for longer than we anticipated, so we would like to evaluate how patients feel about receiving pharmacist consultations over the phone or by other remote means. There are a couple validated scales that we plan to administer, one being the SIMS, or the Satisfaction and Medication Survey, and the other being the PAM-10, which is Patient Activation Measure. So this tool speaks to the ability of the patient to recognize the occurrence of a significant chemotherapy-related toxicity and their ability to take the appropriate action. From the COVID-19 Student Engagement Award, we are also leading a national survey across cancer centers in Canada to collect pharmacist and manager experiences about changes to clinical oncology service delivery during the pandemic to learn from and perhaps build on the framework. This survey and interview is expected to be released end of this month, so if you are an oncology pharmacist or practitioner, stay tuned. So I just want to thank you, and our contact information is here in case you don't have a chance to ask a question at the end. And I believe Alia has some more to share about her experiences at Odette. Thank you.
All right, thank you very much, Maria. And as you suggested, we're kind of maintaining the same theme with cancer therapy for the next presentation. So as a reminder for anybody that has questions for Maria, if you can please indicate P5 prior to your question, that'll help with sorting them out at the end. So thank you very much, Maria, for your very interesting presentation. So last, I would like to introduce Elia Sauer. She is an oral chemopharmacist at the Odette Cancer Center at Sunnybrook Health Sciences Center. She led the development and implementation of the oral anti-cancer medication program at the Odette Cancer Center Pharmacy. She hopes to combine established methods of continuous quality improvement to daily clinical care in oncology pharmacy to improve the delivery and reach of clinical pharmacy services offered and to eliminate care silos. So her presentation is up on the screen today, and it's called Virtual Model for Oral Anti-Cancer Medication Pharmaceutical Care Delivery During the COVID-19 Pandemic. So handing it over to Aaliyah.
Hi, everyone. Thank you so much for the opportunity to present today. So today I'll be presenting on models of care during COVID for the delivery of oral anti-cancer medication services. So oral anti-cancer medications, or OCAMs, as I'll refer to it moving forward, offer the benefit of convenience. These are oral drugs that patients can take on their own at home, but they still require clinician oversight. There's still the risk of drug interactions as well as toxicities that do require clinician involvement. Prior to COVID, the Sunnybrook Odette Cancer Center had in-person visits with the medical oncologist, but in between those in-person visits, the OCAM pharmacy team contacted patients for proactive assessment using virtual methods, so either phone or online platforms. COVID obviously created this urgent need for new models of care with less reliance on in-person visits and increased infrastructure and capacity for virtual models of care, including OCAM drug access, laboratory monitoring remotely, symptom assessment, as well as allied health services such as social work and dietitian. And this is sort of well portrayed in some of our key clinical guidelines like the American Society of Clinical Oncology and the counterpart European Society. And so our first problem then is, what mechanism will we use to facilitate ongoing OCAM access while we're trying to limit physical encounters at the Sunnybrook Odette Cancer Center? And so if you look at the pre-pandemic model, the patients at the center, they come an hour ahead of their appointment to do blood work at the center, which is reported into the EMR where all clinicians can see what the blood work is. The patient then goes to their physician appointment, they sign consent for the treatment they've chosen, the clinician enters this order into the computerized physician order entry system, They meet with a nurse to review the toxicities of the treatment in more detail. They're immediately sent to the pharmacy at the cancer center for drug funding navigation, as well as a best possible medication history, and they're introduced to the oral anti-cancer medication team at that juncture. The OCUM order in CPOE is then verified by a pharmacist, so reviewed for blood work, for height, weight, for end organ function, and then finally a face-to-face consult with the pharmacist is had with the patient to make sure that when they go home, they know exactly how to take the drug. Looking at the pandemic care delivery process, so the patient's still at the center of this journey, but they're going to a local lab for blood work. The physician may or may not have this local blood work by the time they speak to them over the phone or via Zoom. The patient then receives a call from the navigator, a call from the pharmacist for BPMH and counseling, and via virtual platforms, we actually were able to do this quite successfully. The key question was, how will we get the drug to the patient? So to solve this problem of how we were actually going to get the drug to the patient while limiting physical encounters, we came up with 3 interventions. The umbrella intervention was ramping up our courier services for OCUM. So the first part was to redeploy technician resources. So we switched from 2 technicians to 1 for OCUM drug delivery. We defined a clear procedure and framework to build into the standard work of these technicians. And then we ramped up virtual toxicity assessments using drug-specific algorithms that we already had developed in-house, because remember, we were doing some virtual care already. Our key measures were the number of packages couriered per day, which was our process measure, the average time it takes to mail out a package, or balancing or workload measure, and our clinical metrics were remote blood work checks, so the number done, the number of virtual toxicity assessments done per patient, and percentage of patients with virtual drug counseling. And these are really high-level process measures that we were using as proxy outcomes. In terms of our method, so the number of mailouts per day, we did an end-of-day tally over a defined period. A workload measure, we used direct observation. So a direct observer was there with a start watch that documented the start and end time of preparing a package. And the end time was when it was sealed and ready for the courier service to pick up. This was done on 2 separate days with 2 different staff complements to ensure we limited bias. The number of remote blood work checks was collected at the end of each day using a real-time method and an actual Excel tracker. And there was a baseline period as well as a study period. The percentage of OCUM patients with drug counseling done using virtual methods was collected retrospectively from the EMR documentation. The study period is March 26th to May 6th, and it was compared to a historical control that we had collected previously. And this is very similar to the number of virtual assessments done per OCUM patient. So our first result is the number of mailouts per day at the SOCC pharmacy. So if you look at our baseline, the median number of packages per day was 3. As of March 19th, we launched our first PDSA, which is a COVID mailout procedure that we deployed with our 2 new pharmacy technicians, and our mailouts immediately went to 14. They then went to 19 in April because we included in the procedure our satellite pharmacy located at the breast center at Sunnybrook. And as you can see, we had several instances where the mailouts per day were upwards of 25 to 28. This is obviously an immense workload. It was essentially an unsustainable workload. And so you'll see in May 28, we launched our curbside pickup service, which I'll speak to in more detail. And couriers dropped to a median of 9 per day. Other things contributed to this as well, such as restrictions loosening up in the city, patients attending appointments, as well as loosening up of some of our visitor restrictions. In terms of direct observation of mail out times, so you can see that the median time per package was 33 minutes. Our breast center times took a little longer. They were newer to the procedure. And we have one outlier at 60 minutes, which was cold chain. And we recognize that we had ongoing challenges with mailing out cold chain packages. It is best to do some of this work a day in advance, and we learned that from the OCC pharmacy procedure, which is a little bit more streamlined. At 19 mailouts per day and 33 minutes per package, we're looking at 10.5 hours per day of pharmacy staff time dedicated to couriering packages out into the community, which translates to 1.7 FTEs per year, which obviously is not a long-term sustainable solution. Was fine for the peak of the pandemic, but things aren't changing anytime soon, so we needed to come up with some different ideas. So this led to problem 2, which is the need to avoid in-hospital encounters in a sustainable way with more options for OCUM access. So you'll recall our mail out per day data where we saw a drop to 9 packages per day with the launch of our curbside procedure. So what is curbside? So a curbside procedure is literally someone standing outside the cancer center at dedicated 1-hour time slots per day for patients and/or caregivers to pick up drug outside. It is pre-arranged, so it's not willy-nilly. People can't just come and expect their package there. It's pre-arranged. It avoids hospital screening, it limits contact, and we still maintain safety and Accreditation Canada best practice standards by confirming 2 patient identifiers. This is a run chart depicting our curbside pickup numbers per day, date on the x-axis and number of curbside pickups on the y. And you can see as we formally launched on May 28th, this was well received quite quickly. It went to a median of 8 almost immediately. And then we also saw a drop in this service to 4 pickups per day as of June 23rd. And this is likely because, again, things are loosening up at the center, and at some point physicians do need to see these patients. And so many patients were starting to attend in-person appointments. This is myself and my colleague Susan Singh standing outside the cancer center just to give you a sense of what we mean. It is literally curbside pickup. Where patients come and pick up their packages that are signed, sealed, and delivered and ready for them to pick up in a sort of hands-free fashion. So what clinical work do we do to support this? So remember in our previous pre-COVID model, there were several checks and balances, several instances where pharmacists reviewed the order, made sure there was a drug information session. So how do we ensure that these clinical services are maintained? So this is looking at our total daily number of remote blood work checks. On the x-axis is date, on the y is the daily number of blood work checks. So we sent lab requisitions with the packages that were being delivered, or we emailed them to patients, and pharmacists instructed patients on when they needed to go. And then with the results, called patients, reviewed the results with them, and did a symptom assessment at that juncture. This allowed for a few things. The first is it allowed for dispensation of multiple months of drug at a time. So remember, if we're trying to limit workload, sending 3 months at a time via Purolator instead of 1 month would be ideal. It also facilitated assessments by the medical oncologist. So when they're calling patients or using Zoom to connect with patients, they have the blood work handy as well. The big fear of this pre-COVID was, how do we keep track? The blood results will get lost. We can't keep track of all these different patients going to different labs in the community. And in fact, we only had 2% of patients where there was an inadvertent lapse in treatment because the results did not come in a timely fashion or a delay in reporting. So this is a service I definitely hope we move forward with in the post-COVID setting. So at baseline, the median number of blood work checks we did per day locally was 2. During the peak of the pandemic, this went to 9 remote blood work checks per day. And now again, as things are opening up a bit, patients are starting to come to their appointments, we're getting to about 6 per day. In terms of other clinical pharmacy services that supported this work, so the percent of OCUM counseling using tele-oncology platforms, so either the phone, OTN, Zoom, at baseline, we were at 16%. During the COVID study period, we went to 91%. So it's sort of an immediate uptake of some of these cool new ways to provide drug education. The number of proactive pharmacist clinical assessments per patient went from a median of 4 at baseline to 7 during the COVID study period. And a lot of that was in conjunction with some of the remote blood work checks, as well as before we sent out the package, we made sure that we had a clinical assessment of the patient so that we felt good about sending drug to a patient's home who wasn't physically seen in the clinic. Facilitators of this process were using some standardized validated tools for OCUM counseling, and I'll show you some of those tools in just a minute. Incorporating TeachBack into the EMR documentation template, so virtual consultations are the best time and place to confirm understanding, so TeachBack was a huge component of that. And the drug-specific in-house algorithms we already had that facilitated these virtual toxicity assessments. And these algorithms also had grade-based interventions. So if the pharmacy captured someone who was having a toxicity, we knew exactly what to do. Barriers were documenting. So we had lots of incoming and outgoing encounters, and documenting each one was challenging. Documenting versus actually using teachback. So, often, asking, do you understand is not the same thing as confirming understanding. We had challenges with OTN. The communication sent to patients are not really clear. They don't specify that this is a drug information session with Alia Sauer, the pharmacist. So patients struggled with what that invite actually was, as well as challenges with webcam and internet speed. Many patients preferred WhatsApp or FaceTime, but of course we had some privacy issues and concerns with those platforms. So this is an example of, and the tool we use at our center, a modified version of the MOAT tool, which is the Multinational Association for Supportive Care and Cancer Oral Agent Teaching Tool, a validated tool that has some key questions for patients to address with the pharmacist as they're embarking upon a new journey with an OCUM. And this is an example of our drug-specific algorithm. So this is just one example with everolimus. So if you click diarrhea, it hyperlinks to a series of questions based on CTCAE grading and CoSTARS, which is sort of a validated remote telephone oncology questionnaire tool. And depending on the grade of toxicity found, there's a series of interventions that have been agreed upon by the physician team here at the center. So in summary, courier services facilitated ongoing access to OCUMs and actually facilitated clinical care for other disciplines as well, speaking to the remote blood work checks and the virtual toxicity assessment. This was a high workload initiative, and curbside pickup was an accepted alternative to having packages sent directly to the home. Pharmacists supervised up to 9 remote blood work checks per day, with few lapses in care due to delays in reporting. We saw a surge in virtual OCUM counseling for new starts, and key facilitators for this were the MOAT tool as well as Teachback. The OCUM pharmacy team was already completing virtual toxicity and adherence assessments pre-COVID, and during the height of this pandemic, we were able to ramp up and scale up these services to meet the needs of patients. So with that said, thank you very much.
And thank you very much for sharing your positive findings with us. It's very encouraging to see, that effort really pay off for your patient care abilities. So again, if anybody has questions for Alia, I'd ask you to put P6 before the question to allow for us to sort it out. Now that this is the end of our presentations, we will have a question and answer period, just like we did prior to the break for all 3 of the presenters. I'd just like to take a moment to thank all of our presenters for sharing their work with us today and for joining us, and to all of you for joining us. And now I will hand over to Annalise to moderate the questions.
Thank you. Thank you, everyone. We have kind of a mix of questions. So I'm going to start with a question that I'm hoping each of the presenters can touch on first, and then I'll go into some individual questions. So this question is from Zubin, and he asks, as we contemplate a second wave of COVID in the fall and the lockdowns that will entail, what advice would you give to the audience in terms of how to best prepare for virtual care delivery in the weeks we now have available? So maybe Sandra, do you mind starting us off with some of your remarks?
Hi. Okay, thanks for the question, Zubin. So yeah, I was reading this and I was kind of thinking about it because I feel the way we're operating now is still with like full pandemic precautions. So we're still operating as if everything is in lockdown. And I feel in, I guess, the 3 or 4 months that we've been operating this way, I feel it's pretty confident. We feel pretty confident in how we've adapted. So I think, frankly, from our end, we would just continue as is because we've already been able to troubleshoot those issues. But yeah, sorry, I don't have any more input.
Yeah, no, thank you. Maria, do you want to weigh in on that as well?
Yeah, I think that we're going to have to keep this open. And plus, we have to find out what patients think of this kind of service, because I think there's another question coming up about this, but a lot of patients who have to travel long distances, there's costs associated with that. And or if visitor restrictions are re-implemented, patients want to be able to receive care either in the comfort of their home or with caregivers present, and avoid lengthy travel to do so. So I think it's important to have these procedures in place and for them to be streamlined to reduce costs and improve efficiency as well.
Mm-hmm. And Aaliyah, do you have anything you might want to add based on your presentation and the workflows you showed us?
Yeah, I think as we prepare to move forward, I think I would make 3 suggestions to my group and as well as others working in this area. And the first is to collect, as Maria said, some patient experience measures, but also I would say some outcome measures. So what's working, what's not working. You know, right now we're really focusing on some process measures, some balancing measures, but I'd really like to see some outcome data. So of patients who were virtually counseled, how many, you know, went home and took their drug incorrectly, so that we can address the gaps and correct our practice as we anticipate a second or third wave moving forward, or we anticipate moving these services into the quote unquote standard of care. I think the second thing I would say is I'd really love to see, so sort of in my work, the body that provides oversight is Cancer Care Ontario, and I'd really love to see some collaboration there, which I believe is already underway, looking at, you know, creating some sort of multidisciplinary, sort of real, like a very practical tool as to how to move forward. Like, is it appropriate to provide diagnoses virtually? Is it appropriate to provide symptom assessment virtually? What symptoms versus what needs to be done in person? So I think those 2 pieces would help us move forward in a more informed way as we anticipate a second wave.
That's great, thank you. I think I'll move into a set of individual questions for each of you and then wrap up with another question kind of for the entire group to answer. So going back to Sandra, we have a question from Catherine. She asks, you mentioned you would offer virtual appointments to patients who may have trouble getting to the clinic when things return to normal post-pandemic. Have you considered offering all patients the choice to attend virtually in order to reduce patient costs and time to travel to clinic?
Yeah, thank you, Catherine. That's also an excellent question. So yeah, this is something that we're thinking about. And one thing that I wasn't able to discuss in my presentation was some of the physician perspective and the nurse practitioner perspective, which is that one of the barriers they've encountered is not being able to do a thorough physical assessment. And that's one of the unique, like, kind of area, that's one of their unique expertise. And a lot of patients that we see say that this is the first time that someone's actually put hands on them to do a physical assessment. So I think moving forward, it's kind of going to be a balance between gleaning really, really valuable information from a physical assessment versus providing equitable access to people, for example, who live remotely or who might have barriers to physically coming into the clinic. So yeah, I think that's something we'll definitely have to think about and iron out as we move along, but yeah, it's on our radar for sure.
Maria, a follow-up question for you. This question's from Nita. She asks, what were the barriers other than accessibility, as you mentioned, to the broader use of OTN or other video platforms for your service model?
Yeah, thank you for your question. I can definitely speak to this, and I wanted to highlight one other barrier, which some of the earlier presentations did discuss. So it's scheduling. So when you're calling a patient and wanting to do a video consult with them, I mean, they may not be prepared for that. So I think we need to establish a way to schedule these in. And of course, this is not something that we're used to. We're not used to scheduling. You know, we just see patients when they happen to come into the pharmacy or when they happen to be scheduled for treatment. And we have that kind of flexibility, but they're expecting, you know, that interaction. But when we don't have that pre-scheduling done, it does limit the ability for people to adapt and prepare for their appointment. And even if we do prepare and set an appointment date and time, sometimes just getting used to that technology has to be, so I think there needs to be maybe some education or familiarity with the platform on both ends.
Great. And then question for Aaliyah from Nancy. She asks, did you consider drone delivery? Nancy's on a bit of a bent with this one. She says, we're doing a pilot test and there are lots more patient receipt options, biometric signature and kiosk options now. So your thoughts on that?
Nancy, that is definitely something we absolutely did not consider. I can be 1000% honest with that. I would have never, even until now, would have never thought of a drone, but that is a very creative, innovative idea. And definitely will give me some food for thought as I'm on the subway tonight. In terms of kiosks, yes, I very much did look into this option. I think one of the challenges we face with the kiosk, which is sort of what gave birth to the curbside pickup, the challenges we face with kiosks are just the sheer cost of our drugs. So for example, Revlimid or lenalidomide, which is a very common drug, one of our highest volume drugs, is about $10,000 per month. And so just the logistics around facilitating a kiosk option and the safety around that, and sort of the government or Health Canada regulations that it always remain in chain of custody were challenges around that for our practice, though I think it could be a very viable option for others.
Great. And then I'm thinking we can just finish up on this question. I'm amazed that we've stayed on time as well as we have. But I'm hoping everyone, and as well as the presenters from our first round of presentations, can weigh in on this one. From Nancy as well, we heard that from Onil that community pharmacy could be more at the table for these virtual primary care conversations. Do you have suggestions as to what has worked for you to be part of these conversations, or have you heard of opportunities where pharmacists could participate? So maybe if Rhea, are you still with us?
Yes.
Great. Do you have any thoughts on this question just to begin with? We'll kind of go through everyone.
Yeah, it's a great question, and it's in, you know, a conference like these where you have people kind of thinking about the problems within virtual care, where it can act as a seed to have more comprehensive conversations and continuous bouncing of ideas with each other. In terms of, I guess, in terms of my own experiences with other individuals, it's really just with the colleges as well as pharmacy associations, as well as personally with MedMe in engaging some of the banner groups who are looking for solutions to help their patients, help their pharmacies at this time. But I think it also stems from, you know, the faculties having more opportunities for people who are engaged in this work to connect with each other, and perhaps even an on more consistent online forum to engage in deeper discussions and collaborations.
Thank you very much. Dee, anything you'd like to add as a final comment?
Yes. So for example, one of the ventures that we're trying to implement is in this very remote area in Moose Factory, where we service First Nations population. And we've been using, sort of tapping into MedCheck program funding to provide med reviews. And the type of med reviews that we provide, I think, goes above and beyond what a typical med review calls for. And myself and my team members have been quite involved with the local community pharmacy as well. And there's only 1 or 2 pharmacies out there. And I think potentially one of them is perhaps more diverse funding models to promote this type of consultative services. And secondly is more integrated platform. Just personally speaking, even just trying to provide a med check, I have to go into, let's say, community computer to get the med profile. And we got the permission to access a local hospital chart to get labs and etc. So often that itself is quite time consuming, almost outweighs the time you get reimbursed. So those are 2 primary things that I have noticed. Mm-hmm.
Thank you. Thank you for sharing those. I'll pass it over to Stephanie now to share any final thoughts that she has.
Some final thoughts with virtual care and pharmacy. I think we should really definitely have more of these forums. It's an arm or a segment in healthcare that will, I hope, not just hope, but I know will continue to stay. And it is a great opportunity for pharmacists to be involved, stay involved, because we do have a lot to contribute, not just because we are experts in medications, but also in healthcare delivery service. To answer some of Zubin's questions, like what some advice for the second wave, we have to really look at how we can borrow some of the learnings from other industries like e-commerce, and also hone in on partnerships between private and public and research and academics, because we really have to establish that now and learn from each other. Especially like just from my work alone, we've worked a lot and honed the process and fine-tuned it, but it's all been related to research and academics, and within the walls of institutions. It's really time to branch out and reach those opportunities to the community, like my community colleagues and pharmacists that also need to do the med reviews and often see my patients outside there. So it's time for them to have access to these tools as well and make it operational.
Fantastic, thanks. I'll pass it to Sandra now.
Hi, so yeah, from our perspective, as I mentioned in the presentation, we've been kind of relying more on collateral from community pharmacists. And even when I'm talking to them on the phone, I feel almost guilty for taking up too much time. So I think reimbursement and more of like a formalized process for providing this information via virtual platforms would be valuable.
Thanks, definitely agree with that one. Maria, passing it to you.
Sorry, hi. With regards to the community pharmacy?
Yes.
Yes, so since we have a community pharmacy, I think there's definitely an opportunity for, that sort of helped us, since we were dispensing the medications, we were able to make it part of our model to do the virtual care, because it was really seamless in how we were able to dispense the medications on site and provide them either virtually to patients or, as Alia had mentioned, with the curbside pickup, which is a great way for community pharmacy also to start getting in the table for virtual service delivery and getting experience with that.
Yeah, and definitely helpful having being able to dispense right at your site rather than having to have conversations with other pharmacists. Aaliyah, thank you. If there's anything you'd like to share.
So I'd like to echo the comment made earlier about learning from other industries and developing partnerships. I think, you know, just as with the first wave or the second wave or how many waves we've had so far, it was really just trying to, you know, like deal with the current emergency situation and just modify what you could in real time and kind of fly by the seat of your pants. And now we might have the luxury of having done some of that work and now maybe moving beyond to think about how can we optimize it. And I think learning from other industries as well as partnerships. So for example, partnering with OTN, are there ways we can make this easier for patients? A better user experience, I think would be a great example. Partnering with CCO, I think is another good example. In terms of community pharmacy, I see huge opportunities for partnering with community pharmacy because at least in my practice, several of these patients are on drug for the long haul. And problems occur not just because of the drug, but because of other things that are happening. So for example, with ibrutinib and hip replacement surgery, we've had several patients bleed because they went for their hip replacement surgery and never stopped their drug. And so I think there's huge opportunities for us to help each other manage these patients. And it's just a matter of how do we develop the infrastructure for those collaborations and sort of reach beyond these four walls and really develop those sorts of partnerships. I've spent a lot of time thinking about this question and sort of what the right forums are. And I think forums like this are a great start, and hopefully they will continue to grow and flourish as time moves forward.
Thank you so much. And thank you again to all 6 of our presenters, as well as Onil for the keynote. Big thank you from me. I'm now going to pass it over to Zubin for some closing remarks for us.
Okay, well, in the last minute or so of our session today, first of all, let me thank all of our presenters, as well as all of those who actually submitted abstracts for review. We had an overwhelming response, and unfortunately, we were only able to accept about 15% of people who applied to present to today's conference. We're looking at alternative vehicles to allow all of those who submitted abstracts to share their work across the open network and through the Center of Practice Excellence, so stay tuned for that. Also, a big thanks to our Abstract Review Committee, Nancy Waite, Sherilyn Houle, Marie Rocky, and Jim Bowen. A very big thank you to our partners at the Ontario Pharmacy Evidence Network, collaborating with the Centre for Practice Excellence in hosting today. And perhaps most of all, a very big thank you to someone not listed on this slide, and that is Annalise. Annalise has been the cheerful, hyper-organized source of all inspiration and energy for this event. So thank you, Annalise, for making today possible. Most of all, thank you to our audience. We had over 100 people attending today, indicating an incredible amount of interest and enthusiasm for this topic. We look forward to hosting other events in the future. We look forward to welcoming you back in the fall to our Center for Practice Excellence Rounds series. And we look forward to hearing more about the amazing work you are all doing to ensure that the patients of our province and our country continue to get the best possible care. In the meantime, thank you for attending today. Thank you for those providing frontline service, and enjoy the rest of your day.